mobile data. Um, Previously, initially we were morphologists. Obviously, morphology is still the cornerstone of our diagnosis, and we build upon that. That still remains. Over a period of time, we are evolving into second generation, third generation, and next generation pathologists. Meaning, the after the morphology came the immunohistochemistry, which helped to support our morphology. But still, morphology remains the cornerstone. And immunohistochemistry we were using for diagnosis and also to guide therapeutics. Then further on, we evolved into the third generation where we need the help of moleculars, not only for diagnosis but for theranostics also. And now we are at the doorstep of being the next generation pathologists where we are going to be digital pathologists. So we have our morphology, we have immunohistochemistry, we have molecular, plus we have digital pathology. And this is going to help us not only in our routine reporting, but also to guide therapy. And this topic of digital pathology will be taken over by another very important, popular speaker. So my job here is to um describe the role of a pathologist here, where you are using morphology plus IHC plus molecular. Now, it's interesting to note that the we are not given more and more tissue, but we are asked to give more with less and less tissue. So that is the difficulty and the challenge that we are facing now. So we have to stretch our tissue so much so that we have to give all that is asked for in the very limited tissue that we are given. So what exactly is precision oncology? So it's the use of therapeutics that are expected to confer benefit to a subset of patients whose cancer displays specific molecular or cellular features. Basically, molecular profiling of tumors to identify targetable alterations and to yield clinically relevant diagnostic and prognostic information. So, it is to deliver the right cancer treatment to the right patient at the right dose and the right time, in effect, to maximize survival and to ensure quality of life. So, now we are shifting from chemotherapy to antibody therapy. So we have these biomarkers that we routinely test on our tissues, and we have the methodology for biomarker testing. We have immunohistochemistry, we have fluorescence in situ hybridization, polymerase chain reaction, and the DNA RNA sequencing. Now, immunohistochemistry is the most popular, well validated, easy to standardize methodology that we are routinely using in almost all our laboratories now because of the ease of standardization. The other fish, PCR, DNA and RNA sequencing are done in few labs. It's just coming up in our state. Now, which uh, testing methodology to be used for which biomarker? It's very important that we be aware of that. For example, if you take ALK, there are many anti-cancer agents to target the protein. Indication is in non-small cell lung cancer. You have an ALK translocation and it is to be done by FISH or IHC. So the testing methodology we should be very much familiar with. Similarly, this you have many other proteins: androgen receptor, BCR-ABL, BRAF, BRCA, c-KIT, etc. And this list continues to grow, and more of these anti-cancer drugs are coming up. So, for example, ERPR is done only by IHC. EGFR is done only by DNA sequencing and the PCR, not by IHC. So, what test to be sent for which biomarker, we pathologists should be well aware. So, this list of anti-cancer age biomarkers and its testing methodology and the list of biomarkers that are important in many cancers continues to grow. So, many of these proteins and these biomarkers are tested for many of the common cancers. So if you look at non-small cell lung cancer, we have a histology-based subtyping into adenocarcinoma, squamous cell carcinoma, and the not otherwise specified category. And in the adenocarcinoma, you have the spectrum of mutations. We all know the KRAS, EGFR, ALK, and so on. And the squamous cell carcinomas, most of them, there is no, it's unknown. The majority of squamous cell carcinomas, 60% of them, there are no mutations, there, it's unknown. Whereas you have the other mutations, lesser percentage of squamous cell carcinoma. So it's important to, for the pathologist to differentiate the histology based, to give the histology based subtyping. And in non-small cell lung cancer, you have 25% of them, there are no mutations. 51% of them, you have biomarkers in clinical trials, and 23% of them have got approved and emerging biomarkers. So, for example, in every diagnosed case of non-small cell lung cancer, they have to send for EGFR, ALK, ROS, BRAF. So, this has to be done in all diagnosed cases of non-small cell lung cancer. So we all know about determining tumor type in small biopsy specimens. So if it's a morphologically non-small cell lung cancer, if the morphologic features of squamous cell carcinoma are present, you stop there. The tissue then goes for PDL1 testing. If the morphologic features of adenocarcinoma are there, it goes for molecular studies, including PDL1. On the other hand, if it's an undifferentiated, where you're not able to make out whether it's squamous cell carcinoma or adenocarcinoma, we basically do two markers, TTF1 and P40. If P40 is positive, we call it a squamous cell carcinoma. And if TTF1 is positive, we call it an adenocarcinoma. And if both are negative, we call it a non-otherwise specified NOS type of non-small cell lung cancer. So this is a non-small cell lung cancer. You can see TTF1 is positive and P40 is negative. So this qualifies for an adenocarcinoma. So this has to go for molecular studies and PDL1. If you look at breast cancer, a newly diagnosed duct carcinoma in situ, you need to do only ER by IHC. Whereas in early stage, stage 1 to 3 invasive carcinoma, you do an ER because they want to know, they need to determine the overall treatment pathway, and they decide treatment with endocrine therapy. HER2 is to be done for overall treatment pathway and for treatment with HER2 antibodies. And also, they do for ER positive, HER2 negative, node negative, early breast cancers, they go for these multi-gene expression panels to estimate the benefit of chemotherapy. And when you have a metastatic breast cancer, you have to repeat ER because they have got endocrine therapy plus CDK4/6 inhibitors. And the second line they look for the PIK3CA mutation because they've got targeted therapy for that. And HER2 has to be looked for because of the susceptibility to HER2 antibody. If it's an ER negative, HER2 negative tumor, they do a PDL1 because they've got the PDL1 inhibitor is available. And you have option to test for MSI MMR. All subtypes of metastatic breast cancer go for BRCA1, 2 germline mutations for PARP inhibitor therapy. And there are options to test for NTRK fusion, and they also go for comprehensive genomic profiling to identify uncommon targets. So basically, we need to know that our tissue is required for all these downstream tests. So the routine breast core biopsy, we do this panel of ER, PR, HER2, and Ki67. And we have these 4 phenotypes. This is what we routinely do. And this helps them to decide the further treatment. Now, the multi-gene assays in breast cancer that are done in ER positive, HER2 negative early breast cancers. The Oncotype DX. There are many platforms. Oncotype DX is the most popular. It's a 21 gene molecular tool. It estimates the likelihood of distant recurrence and the benefit of chemotherapy. So similarly, they have the MammaPrint, EndoPredict, Prosigna, and so on. So these are now commonly done in early stage breast cancer and needs to be done. If you look at colorectal cancer, colorectal, all diagnosed cases of colorectal cancer, you have to do MMR, MMR IHC, or MSI by PCR. Now, what is that for? We do an MMR IHC firstly to estimate or to determine whether the patient has got Lynch syndrome. Now, how do we do that? So, if all MMR proteins are intact, you don't have to do anything more. If MLH1 and PMS2 are absent, that is the usual combination, they further go for BRAF analysis or MLH1 methylation. If BRAF mutation is present, you again stop there. If there is no BRAF mutation, you go for MLH1 methylation testing. And if there is no MLH1 methylation, the patient goes for genetic germline testing for Lynch syndrome. Now, why do you want to identify Lynch syndrome? Because you need to look for other malignancies in that patient, like endometrial cancer, ovarian cancer. He's likely to develop further cancers, and a family counseling and a family screening and surveillance. Now, it is not only for finding out whether the patient has got a Lynch syndrome, but also it's got other implications. For example, awareness of MSI status of the tumor helps with risk stratification, guiding therapy selection for patients with colorectal cancer. Stage 2 patients with MSI high tumor typically have a better prognosis than stage matched MSI stable cancer and do not benefit from 5-fluorouracil adjuvant therapy. Instead, they may benefit from PD-1 immune checkpoint blockade. So, the implications of us doing the MMR IHC on all diagnosed cases of colorectal cancer are very widespread. And we know that there is a molecular classification for colorectal cancer into the immune, canonical, metabolic, and mesenchymal. It is an upcoming classification based on the MSI status and other mutations. So this is how we look at IHC. The MLH1, in this particular case, MLH1 and PMS2 are lost in the tumor cells, whereas MSH2 and MSH6 are retained. So this is one sort of deficient MMR that we see. The other combination, you have an intact MLH1, PMS2, and a lost MSH2 and MSH6. So this is how the deficient MMR looks like. Now, if you look at endometrial cancer, every diagnosed case of endometrial cancer, you have to follow this pathway. So you do an MMR. If it's deficient, it goes into the MMR deficient category. If it's intact, you do the pole mutation, it goes into the pole category. And if pole is wild, then you do a P53, it goes into the P53 wild category. And if it's mutant, it goes into the P53 abnormal category. Now, if you don't do any of these, then your endometrial cancer becomes unclassifiable. Now, why do we have to classify these? Why do we have to do all this in endometrial cancer? Because the molecular classification of endometrial carcinoma has got a major impact on surgical decision and staging as far as the treatment is concerned. So you have 4 categories: the pole mutated, the MMR deficient, the no specific mutations, and the P53 abnormal. For example, if you look at the P53 abnormal, they are aggressive tumors, regardless of grade and histology. And they've got, so the category has got a major implication on their treatment protocols. So this is an uterine endometrioid carcinoma. So all the endometrial cancers go for this panel up front. ER is strongly positive, P53 is wild, MLH1 and PMS2 are lost, MSH2 and MSH6 are retained. So it's a uterine endometrioid carcinoma, MMR deficient category. And this is a uterine serous carcinoma. You can see morphologically. So all the MMRs are retained, MSI is intact, ER is positive, P53 is mutant, and P16 is positive. So this goes into the P53 abnormal phenotype. So all endometrial cancers, we have to give the phenotype. And that is true for endometrial curating. So the best sample to go for the molecular and your IHCs are the endometrial curatings, which are well fixed and well processed. HER2 is routinely done now in many cancers, including gastroesophageal cancers. And of course, the PDL1 scoring. PDL1 scoring is another very important aspect of precision oncology, where you look at the PDL1 expression on the tumor cells and also on the immune cells that are infiltrating the tumor. So you have a tumor positive score, that is number of positive tumor cells by number of viable tumor cells into 100. You have a combined positive score and an immune cell score, which gives you the percentage of immune cells that are infiltrating the whole tumor. So all this information is required. These are all biomarker, prognostic and predictive markers are important for them to make their treatment decision. And we know about liquid biopsies. Liquid biopsies are you're looking at the circulating cell-free DNA. You're extracting the circulating cell-free DNA from the blood of the patient, from the plasma, and then you do the same molecular study. So when do you do these liquid biopsies? When tumor heterogeneity is suspected, because it gives the entire mutational landscape instead of a one-time biopsy. It's very useful for monitoring disease progression, for minimal or molecular residual disease, prediction of recurrence, monitoring of treatment response, early detection of resistance mechanisms, assessment of tumor burden, tracking clonal evolution of tumors, tumor mutation burden, when rebiopsies are not safe, not feasible, and when there are multiple tumors. Now, liquid biopsies are routinely being done in lung carcinomas, pancreatic carcinomas, and also breast carcinomas, and their lung carcinomas, they are well validated. Now, this is just an introduction of the biomarker tests that are done in the routine cancers. Now, coming to the main gist of my talk is, what is our role now? So we need to answer some questions. How safe is the tissue in our hands? Because it is now coming down to tissue now. Are we ensuring good quality tissue that can give all the tests in a proper way? How judiciously are we going to utilize the available tissue? Because as I already mentioned, we are having to do more with less. Can we ensure adequacy of tumor content? So these are the questions we need to ask ourselves. So basically, we are now the guardians of tissue. So what is precision pathology? So it's the ability to make use of available tissue to offer a reasonable diagnosis with the help of necessary ancillary testing to guide therapeutic treatment decisions. So we have to give a diagnosis. We have to guide the necessary ancillary testing. We need to know which test to do for which biomarker for which particular cancer, so that they can make the right therapeutic treatment decision. So basically, we are custodians of tissue. We are supposed to ensure good quality of tissue. We have to ensure that the tissue is well utilized and adequacy of tumor content. Now, we are all working with small biopsies now. Core biopsies, cell blocks, which come in from breast, lung, endoscopic biopsies, lymph node biopsy of tissue masses, EBUS guided biopsies, EUS guided biopsies, endometrial curettings. Now, how do we handle these tissues? It's a big challenge actually. Now, before that, let's go through journey of tissue right from the time of its acquisition to the time it goes into the block. Now, before that, we should all know that we always take an informed patient consent before taking the biopsy. The proceduralist takes this consent, and the consent covers the risks of the biopsy, because now these small biopsies taken from inaccessible areas are high risk biopsies. So the consent is taken to cover the complications of the biopsy. Apart from that, you need also consent from the patient for using his tissue for standard of care medical practice. And also, you have to have his consent for enrollment in clinical trials in future, consent for translational research in case of death. So these additional consent are not there, as far as I know, in our country now. It is coming up soon, will be there. So basically what it implies is that the patient has got rights for all this. And how does it imply to us? We need to know what are the tissue retention requirements. We need to know why we should keep the tissue in the block and not exhaust it. We need the tissue for standard of care testing, for our morphology, for a reasonable diagnosis. We need immunohistochemistry backup. We need to do the biomarker test. Apart from that, tissue has to be retained for second, third, fourth opinions in if required. Those are all the rights of the patient to pursue medico-legal options if required. Clinical trials. If the patient needs to enter into a clinical trial for testing for new biomarkers, there has to be tissue left in the block, and translation research if required. So these are basic rights of the patient which we should be aware of. So let's look at the pre-analytic factors affecting biomarker testing. So how safe is the tissue that in our hands? So let's look at cold ischemia time, fixation, processing, the use of strong decalcifying agents, prolonged storage of FFP blocks, humidity, and so on. So right from its acquisition, from the time the tissue is procured, it's always best to have a tissue acquisition team. In this team, you have the referring physician, you have the proceduralist, you have the pathologist, and you have the oncologist. Now, it's good that all the members of this team be aware of the case, how we're going to do the biopsy, how much tissue will be required, what are the downstream tests that we are anticipating. So, right from the time of acquisition, all the members of the team should be aware of the case. This is very important. It is an ideal situation, but if it can be done, it's very useful. Now, most important person here, perhaps, is the proceduralist and the pathologist. Now, the person who takes the biopsy, it can be a surgeon, it can be an interventional radiologist. He should be well aware of the case. What is the tissue is going to take? Is it a lung cancer? Is it a breast cancer? What is the, or is it uh, tumor in an inaccessible area? What is it likely to be? What are the tests that need to be done? So he needs to know how much minimum tissue is to be taken out. You can't just take out the tissue, take the biopsy, and say, I got only so much. Again, he'll be cutting a sorry figure, and we also will be at a loss. He should know the nature and volume of fixative that he's putting the tissue into, and be aware of the cold ischemia time. Now, so apart from awareness of the case, he needs to know when he should go for an FNAC with the core needle biopsy. He should know whether a ROSE should rapid on-site evaluation to be done or not. So what is recommended is that 3 separate needle passes using 18 to 20 gauge needles, and when to do a FNAC with specimen for cell block. So it is very, very important that the proceduralist be aware of all this right before they plan the biopsy. Now, I put up this figure every time I discuss about the cold ischemia time. The cold ischemia time is the time interval between the procurement of tissue to the initiation of fixation. So this was a mastectomy specimen that was done on the previous day. It came to our laboratory the next day. So it's already 24 hours. Now you can see that the tumor was well inside the specimen. There is no way that formalin can reach the tumor. And this is the result. This is the grading. This is the ER. So this is almost uninterpretable. It's lost. You cannot do anything about it. So what can be done is that if the surgeon, whoever is the proceduralist, if he can just bisect through the specimen so that the tumor gets exposed to formalin, especially when it's coming from a remote area, he can keep the cold ischemia time 2 minutes to less than 1 hour. Now, in this particular case, the cold ischemia time is around 30 hours, or rather more than 24 hours. Doesn't make any sense. So if this can be done, it's a very simple, you can ask your surgeons, you can educate your surgeons for this. When your specimens, especially these large specimens, whatever it may be, coming from another far off institution. So significant biochemical alterations occur in tissue within 10 minutes of anoxia, causing RNA and protein degradation. Obviously, tissue hypoxia reduces the yield of nucleic acids, and you have a loss of 30 to 50% mitosis due to delay in fixation by 2 to 6 hours. We have to keep the cold ischemia time to less than 1 hour. So this challenge is for major specimens. Now, fortunately, now we have a lot of core biopsies. So in core biopsies, that biopsy goes directly into formalin. So there is no issue of cold ischemia time. But now here the issue is that the fixation, what is the fixative that you use? 10% buffered formalin at pH 7 proximate is mandatory, or it is recommended and mandatory for consistent immunostaining and for molecular tests than unbuffered formalin at higher or lower pH. Now, unbuffered formalin at higher or lower pH reduces the DNA solubility, induces DNA degradation with high frequency of non-reproducible sequence alterations due to cross-linking of cytosine nucleotides causing artificial mutations. So, the results of our biomarker testing are dependent on the concentration of the fixative, the temperature, and the pH of the fixative. So, 10% buffered formalin, 6 to 72 hours recommended fixation time, optimum 24 hours. So, over fixation and under fixation can affect biomarker testing. So, the recommendation is to use 10% buffered formalin. Ensure adequate volume of fixation on receipt of specimens. So you have to train your receptionist or whoever technicians on that. Make sure the volume of fixative is the correct amount. Ensure the quality of fixative on each specimen reaching the laboratory. Preferably change the fixative and re-immerse in fresh fixative. And preferably cut through tumors in major resections on same day. So if you don't have time to gross the specimen, at least you give a cut right through the tumor, just one cut, so that your cold ischemia time is minimized. And keep fixation time to 24 hours. For us in our lab, we use a Schiff's reagent to make sure the fixative is that for specimens coming from outside is formalin. So you put a drop of Schiff's reagent to the fixative and it gives a dark purple color immediately. So that tells you that's formalin. pH is very important. You make a regular check on your pH. This is unbuffered formalin. You can see the pH is around 6, between 5 and 6, whereas buffered formalin gives a pH of 7. So there is a major difference when you use buffered formalin. Now, going on to grossing of these small biopsies. So we are all familiar with grossing of major resections. We have got, we train our PGs on that, and it's all there. Okay. Now, what about these small biopsies? So we have, for example, 1, 2, 3, 4, 5, 6 bits of core biopsies here. Now, these should not go into single block. They have to go into separate blocks. At least 1 per block is the ideal, at least 2, not more than that. So the more the tissue that you get, make it into more numbers of blocks, because you need these blocks for further your studies. For immunohistochemistry, you'll need it for molecular, you'll need it for to retain the tissue. So it's much easier to retain several blocks instead of 1 block, and you use up all of it for your testing. Gradually, it gets exhausted, and again, you're cutting a sorry figure. So this is a very, very important thing. Still, we still have many of these core biopsies coming into 1 block. Now, how does processing affect biomarker testing? Extent and intensity of immunostaining and molecular testing is said to be superior with isopropyl alcohol rather than with ethanol, methanol, or acetone. In clearing, xylene versus chloroform shows conflicting results, so there is not much difference, is what the studies say. Dehydration and clearing at 4 degrees centigrade attenuate background staining. Duration of dehydration increases the intensity of immunostaining, and duration of clearing has no impact. So it's basically the cold ischemia time, the fixation, the duration, the nature of the fixative, and the duration of fixation that is the most important part of it. Now, if you look at how to handle these small biopsies from the lung, EBUS biopsies and US biopsies, we routinely get from in many of our institutions here. So what is the recommendation is that the bronchoscopist gives you a drop of tissue, or a drop of this tissue on the slide, and the sample is dropped into 2 slides. The first one is air dried and stained for a rapid on-site evaluation. The second goes for a alcohol fixation and pap staining. The remaining sample goes into cytolite solution. It is centrifuged and a cell pellet is formed. Whereas the biopsy goes into for formalin and is processed in surgical pathology. And the cell pellet, then they make into thin prep slide, which can be used for alk gene rearrangement by fish. Whereas the cell block, we all make the cell blocks, goes for immunohistochemistry and the molecular tests if required. And the residual cell pellet and supernatant goes for molecular studies. Now, basically, what this indicates is that every drop of blood that comes out of a difficult biopsy has to be utilized. So we can make our own standard operating procedures to make sure that the tissue is very well utilized. Whatever drop is given to us needs to be salvaged. And of course, these core biopsies go into formalin, and we routinely do the surgical pathology for IHC, PDL1, ROS, and GIS if required. So we have got a protocol for our rapid on-site evaluation. Many centers are doing the rapid ROS, rapid on-site evaluation. So we've asked our clinicians to send us, if they require ROS, to send us 6 slides, a minimum of 6 slides, to be sent in 95% isopropyl alcohol. 2 slides we do a rapid HND and we give them the adequacy. 2 slides we do a pap stain, and 2 slides we keep it there. In case we don't have enough tissue for the moleculars, we keep it there for molecular studies with our protocol for rapid HND. So we are able to give the adequacy in 20 minutes, just like a frozen section. This is one of our cases. You can see this is an HND. We do a rapid HND. You can see it's very much adequate to the non-small cell carcinoma. This is the biopsy. So if you look at we outsource our molecular tests. We don't have molecular testing in-house. So we thought we'll have an audit on how good is our tissue. What is the quality? How do you assess the quality of our tissue? So we could retrieve around 66 cases where we sent blocks outside for molecular testing. And we got the results in around 94% of them. And the results failed in 6%. Now, this failure rates, if they go up, it's an indication that your quality of tissue is not good enough. This should not happen. Then it's better you go back and check where you're going wrong. Is it your cold ischemia time? Is it your overfixation that is causing this failed results? So it's good to have audits on these molecular tests to check the quality of tissue. Now, all said and done, we still have these challenges when we have the single block. So here you have a non-small cell carcinoma. This is an endobronchial biopsy. You can see there are 4 bits of tissue in this block. So even these 4 bits, if they could have gone at least into 2 blocks, it would have been easier. Now, this block had come into us for review, but if we start separating out the tissue bits from these blocks, we're likely to lose on tissue. So it's better to leave it there, try to make the best of it. And only this small bit showed the tumor. And then obviously non-small cell carcinoma. Now, what we do when there is a single block is that we discuss with our trained technician as to, can we do both IHC? Will we get enough tissue to do both IHC and molecular with this bit of tissue? So we consult our technicians for that. They are the best people for that. Now, this bit of tissue seemed to be enough. So, and the oncologist wanted us to do a IHC also. So we did an IHC, and this TTF1 positive, P40 negative. So this has to go, obviously it's an adenocarcinoma, it has to go for molecular testing. Now, what about this block? You can see another block that came in. The tissue is almost exhausted in the block. There is only one tiny fragment showing a non-small cell carcinoma. Now, if we straight away go and do an IHC on this, there will be no tissue left for molecular. So the decision on whether to go for IHC or molecular is to be made by the pathologist in consultation with the oncologist, or you make your own judgment. At least leave tissue there. Do not exhaust it. Once you exhaust it, it will be, they will not repeat the biopsy, and there is no question of asking for a repeat biopsy. It doesn't make it doesn't it makes you feel very bad about that. So the judgment on what to do with this small bit of tissue, whatever you are left with, is is the pathologist's job. Now now we are frequently getting these cryobiopsies. So this was a 40-year-old lady. You can see she came with breathlessness. The CT scan showed these miliary showering of nodules, and it looked like a metastasis. And this was a cryobiopsy. This is a new method of lung biopsies where you get large chunks of tissue. It's actually very good. You can see, but here you can see the most of it is normal lung tissue. Here there was a small focus of tumor, papillary neoplasm with some psammomatous concretions, possibly metastasis from a ovarian serous or something. Anyway, the question is, should we go ahead with IHC? Shall we straight away go ahead? The only one block showing this tissue, go straight away with IHC and prove its metastasis, or primary is still a possibility. So here we thought we'll wait for the PET scan or something, PET scan, if the patient was willing to do a PET scan from our institution before going into IHC, because we may have to leave tissue there for molecular. So anyway, we didn't do anything about this case. And I think we decided to leave the tissue there in the block until we got further information or further information from the treating oncologist. So, yet another 60-year-old lady. This lady had been treated for clear cell ovarian carcinoma some 6 years back. Now she came with hematemesis. And on imaging, they found a mass that was eroding into the stomach. So this is the gastric biopsy. You can see the majority normal gastric mucosa with a small fragment of tumor. Now, here again, we hold it. I mean, we know it's a clear cell ovarian carcinoma. We can directly go ahead and do an IHC, do a panel of 4 markers, and prove that it is ovarian. It looks very much like a clear cell ovarian carcinoma. But we decided to discuss with the treating oncologist, should we go ahead with IHC, or do you want tissue? Would you want tissue for a molecular? Because in which case, if we start with IHC, we won't have tissue for molecular. So before we start this on what to do, we have to discuss with the oncologist and be aware of what to be done. So in this particular case, oncologist told us to proceed with IHC because there was, that's what he said, there was no role for immunotherapy for this particular clear cell ovarian carcinoma. So that's what we did. And that was a clear cell ovarian carcinoma metastasis. Now look at this block. You can see there are so many cores of tissue stuffed into this single block. So we feel very sad because this could have been made into 3 or 4 blocks, and we could work very comfortably with one of them to do our panel of IHCs. It's a high grade B cell lymphoma. Naturally, it would require a whole panel of 10 IHCs minimum, and we may require molecular. So if one block could be preserved, it would have been so much easier for us. So please, we should understand that we should refrain from putting all these core needle biopsies into one block. Again, invasive breast carcinoma, IHC plus or minus molecular. But IHC is mandatory, obviously, for invasive breast carcinoma, we know that. But we are supposed to keep tissue there for a molecular in case for comprehensive genomic profiling or whatever is to be required. We need to know the retention, the requirements for retention of tissue. And this was, again, 3 cores into one block. This was interestingly a lipidic adenocarcinoma. So whether it was a primary, she had a history of periampullary carcinoma, or was it a lipidic mets from a periampullary carcinoma? This again would require IHC, obviously, plus molecular. So if you separate out these blocks, separate out these tissue bits from this block and make it into 2, you are likely to lose tissue, very precious tissue. So these are the challenges that we face. And yet another scenario of the challenges that we have is, I would call it a tissue nightmare. This is a 18-year-old boy who presented with a large abdominal mass. You can see it's a huge mass, filling almost all of his abdomen. And this biopsy was done from outside. It was a core biopsy done from outside, and the block and the slides came in for review. You can see already so many sections, 12 or 20 sections of H&D have already been done on this tiny weeny bit of tissue, and the block is almost exhausted. And looking at the slides, most of it was normal renal tissue. So the imaging said that it is a large suprarenal mass. Okay, and this was a tiny weeny bit of fragment showing the tumor. Now, what do we do with this tiny bit? So this is all the renal tissue, and this was the tumor. Obviously, a small round cell neoplasm by morphology. These are the differentials. It can be a neuroblastoma, Ewing sarcoma, lymphoma, or rhabdomyosarcoma, desmoplastic small round cell tumor, any other undifferentiated round cell sarcoma. Now, how do we proceed? We have only one bit of tissue. We may need both IHC and molecular. Being a round cell neoplasm, we have to do an IHC because that is the only way that we can guide a molecular. So we decided to go for the IHC. It had to be done with that tiny bit of tissue. Fortunately, we did the panel as for round cell neoplasm, and it took up NKX 2.2. So that pointed towards an Ewing sarcoma or Ewing family of tumors. Then, of course, you can't stop there. For Ewing sarcoma and its family of tumors, it will require a molecular. So where is the tissue for that? So we said it's, you can imagine what will be remaining in the block after all this, after all the IHCs have been done. So we asked for a repeat biopsy. And again, so sadly, it came out as there was only necrotic tissue in this biopsy, no viable tumor at all. So now what do we do? So we have a first biopsy, which is almost over, and second biopsy showing only necrotic tissue. And the next challenge is, should we go for a single gene testing? Should we go for a targeted NGS panel? Because Ewing family of tumors for other round cell sarcomas also need to be covered. Anyway, we sent both the initial block and this block for a single gene. We decided to go for single gene testing as for Ewing sarcoma. Uh, Ewing sarcoma, and fortunately for us and for the patient, it came out as positive by FISH. EWSR1 gene rearrangement was positive because Ewing sarcoma requires a molecular confirmation before they start treatment. So, managing tissue. Going back to that particular case, you can see there was no need actually for so many sections to be taken because, in fact, I would call this so much of wastage of precious tissue. So before you go ahead and do so many H&D sections, you take so many sections, ribbon sections, and you H&D on that, we fail to understand that tissue is so important. It may have to be retained for more important tests. So again, a scenario. You can see this. This again a block that has come in from outside. You can see so many H&D sections. So many tissue bits have already been into this single block, and so many H&D sections already taken, and some partly done IHCs. The tissue in the block is exhausted. Now this was a lymphoma, partly done IHCs, tissue exhausted. Now without a conclusive diagnosis. This again, I think I would say the pathologist does cut a sorry figure because once you start working with IHCs, you have to make sure that you give a proper diagnosis, you end it, or you if you start working, you should get the diagnosis and not halfway done and make it like this, where the block is exhausted. So, working with limited tissue, I feel requires a lot of planning your workflow well ahead. What are you going to anticipate? Will you get the diagnosis at the end of the whole thing? Have you made your tissue into several blocks so that you can work with one block and leave the other block in case you need to, in case tissue needs to be retained? So, basically, this is the end, the summary of my talk. Our roles start with tissue acquisition. So in case our proceduralist is unaware of the tissue acquisition, what he needs to know, we have to educate him. Awareness of the right test to be done for the right case. Prolonged cold ischemia time, acidic pH, prolonged formalin fixation have deleterious effect on tissue and its nucleic acids. So we have to ensure good quality of tissue. When your tissue is limited, you need to plan your workflow well ahead. So right from the time it comes into your laboratory to the time it's safely tucked into the paraffin block, it is our responsibility. And even after that, it is our responsibility to make sure it is well utilized. And if you think your immunostains are not working as expected with controls, or your molecular tests are failing, go back and check the journey of tissue and make necessary corrections whenever required. It's very important. So we have come to the situation when the tissue has become more important than our diagnosis now. So our roles are changing from just giving a diagnosis to managing tissue. That's very, very important. So basically, we should all refrain from exhausting tissue in the block as far as possible. So thank you all.
Thank you, Neena Madam, for the clear and informative talk on the role of pathologist in precision oncology. Here, the importance of handling of tissues by the pathologist is very well explained. And most of us are not that much exposed to molecular pathology at present. So I'm sure that this session is a good sensitizer for us, and that we have 5 more sessions to follow in the coming weeks before the IAPM chapter meet. And kindly attend these sessions so that for the proper understanding of the discussions in the much awaited slide seminar. So the next, requesting you all to attend the following sessions also. So the next session is on the coming Friday by Dr. Amit Kaur, consultant molecular pathologist at Kogilab and Dhirubhai Ambani Hospital, Mumbai. The next topic is molecular pathology and emerging trends, tissue biomarkers in precision oncology. And it's at 7:30 p.m. the coming Friday. So we are extremely thankful to Neena Madam for redoing the session, taking all the pains in redoing the webinar. And we also thank Roche for helping us in organizing this webinar, and also all the participants. We also thank all the participants for attending the webinar. And if there is any Q&A session, any doubts?
Yes, just one quick question, ma'am, Neena ma'am. Ma'am, when we are doing the IHC and preparing the histopathology report, if we have more than one block or at least 2 blocks, right? Do we also note down the percentage of tumor content in the block? Because going forward, molecular pathology, each and every labs for the NGS, they will ask for minimum tumor content percentage basically. So are we doing the tumor content listing of each tissue block, whatever we have identified in the tumor content in the tissue block?
Well, yeah, that's a good suggestion, Silimbrashan. We don't usually do it, but when we are asked to send for molecular, we select the block.
Okay.
Make sure there is enough tumor tissue, and then only we send.
Okay, that's great, ma'am. Actually, because this is one of the main pain point for the NGS laboratories, basically. So they will ask for the minimum tumor content, because many times when they are sending 1 or 2 blocks, as you rightly mentioned, are showcased in this slide presentation, we used to get the blocks in the labs which doesn't have tumor at all, or it will have less than 10%, less than 20%. So what will happen is the patient will pay high for the comprehensive genomic profiling, and the report will just pass the QC, and the report will be generated as a normal report. But what will happen eventually is that the molecular depth of understanding the tumor will not be there actually. Or sometimes it will be just a qualified report, or sometimes it's a failed report, and it will take one more long time. We need to arrange for the block to reach the USA or anywhere the lab, and then the process need to be repeated again. So if we can follow the tumor content of the block, at least in the histopathology report, or as quickly as possible whenever they are identifying this one, so then it will be easier for the molecular the labs to do the further process actually. So that's one question.
Yeah, actually, we need, as you said, rightly said, we need to select the blocks
Yes,
before
yes,
sending for molecular. We have to look into
correct,
the slide, make sure that that particular block has got adequate tumor, and then only send for molecular.
correct, correct, correct.
Yeah, that is
That's
also our responsibility. Yes.
yes, yes, ma'am. Yes, absolutely. It's a pathologist's responsibility, and they are the one who is going to select the right block for the testing, basically.
So what we do is that we have, if we have two blocks containing tumor, we take the lesser tumor content block for IFC and we keep the more content for molecular.
Great, great. That's a great
What we
information.
do.
Yeah.
Okay. So it should not come back and say we don't have enough. I mean, your molecular should not come back to us and say we don't have enough tumor, or we couldn't do the test, or it comes back failed. It should not happen.
Correct, correct. Absolutely, I agree with you. Because the reason is that in the IHC, like max to max, we will do 5, 6 the protein or the genes. We will do it for them basically. But whereas in the NGS, it will start ranging from 12 gene and it will go to 50 gene. It will goes to 150 gene. It will goes up to 500, 600 genes. So if they have to do that much of number of genes, all the alterations, then they need adequate number of DNA quantity in that one. So that's one of the going to be the challenge one. Thank you so much.
Yeah, we'll hear more from the molecular pathologist.
Yeah, of course. Next topic will be that. Main topic will be there. Actually.
Okay, Neena, can I ask you a few questions, please? Good
Madam.
evening.
Hello, madam.
Okay, good evening. A very good presentation. Very simple, you said. Okay. Now, one question is: we used to remember when we had this CAP protocol, we were formulating the protocol for the Kerala pathologist. We were talking about warm ischemia time, so we were having was a little bit apprehensive whether the clinicians will be able to furnish that. So, what is this? Do we really need to depend upon warm ischemia time now? I mean, it's very difficult for us to get that time at all because it's shorter period, right?
Yes, madam.
So I stick to cold ischemia time. Is it okay?
Cold ischemia time is the variable that
is okay. That will they will be able to record. But I don't think warm ischemia time is anywhere near. I mean, the clinicians to give us the warm ischemia time because we had a discussion on that regarding right. That's so.
Yeah.
So we don't get that warm ischemia time. Cold ischemia, I think we can decide on that. That's point number one. Point number two is you said that of course we do cut the specimens in the evening, but sometimes some of them do come after 5:30 when there aren't any senior residents there in the department. So how good can we expect the surgeon to cut the tissue, cut the specimen and then give it to us the next day? Because sometimes what we find is the whole specimen becomes everted. Especially you definitely would have seen hysterectomy specimens and all. So especially in hysterectomy specimen, there it becomes really very difficult to sample and to find out the depth of invasion and the serosa clearance, etc. Once it gets, sort of cut by the surgeon and it's everted the next day. So I'm not very happy in telling them, but maybe sometimes yes.
Yeah.
So that's one thing. Okay, so what about your surgeons? Do they cut the specimens right and give it to you, or is there anything like that?
Madam, regarding your first question about warm ischemia time, actually, warm ischemia time is the time from the time the patient, the surgeon ligates the tumor, ligates blood to the time the tumor comes. So that time is not very significant.
Yeah.
There's no much stress on that time.
Yeah.
This is all on cold ischemia time. So that I think we need not be too much bothered about. That's not much. There's not much implication on the our testing. Now, regarding the madam, as you said, for breast, I feel bisect through the specimen if it's a surgery done late into the day will not harm a mastectomy specimen is my understanding of it. When it comes to uterus, as you said, it everts. And what we do in our lab is that all the uterus specimens are grossed, at least bisected by the pathologist before they leave by around 6. But after 6, if it comes in, obviously there is an issue. There will be an issue. And uterus, we don't ask our surgeons to bisect. We do it. We do the grossing, meaning at least just cut through, bisecting the uterus. Now, regarding moleculars in uterine pathology, it is best to get the moleculars done on the endometrial curettings itself upfront. That is the best sample to send for molecular. So of course, the staging part matters when it comes to, as Madam rightly said. But if you have done your moleculars on the endometrial sampling upfront, then the molecular will not suffer when the hysterectomy comes in. Obviously, the staging matters. That we'll have to decide how we're going to. Each institution will have to have its protocol and but we don't usually ask our surgeons to cut the uterus.
One more question, Neena. You mentioned about many cores being embedded in one block. So we also do get a lot of blocks like that, especially from outside. And, especially, and then when we send it for moleculars, we have got a molecular lab. So the kid comes and asks us tumor cellularity at the madam parayo and okay. But the problem with me is, problem I have is, you have a lot of cores. Okay. Some of them are totally necrotic. Some of them may be 50% necrotic. Some of them may be having the tumor cells. Okay. Now they say, what is the percentage? I'm really sometimes perplexed because, my understanding in molecular is that they take one core from there, isn't it? One for that thing, I think when you give it for molecular studies, how do they decide which core to take from there? That's one thing which always occurs in my mind. How do they decide? So I always ask the lady who comes from the molecular lab, should I mark that fragment which has got the tumor cells and the other fragments which are not necrotic, we can be ignored. But he said that block I can I don't understand how that happens. I don't know, where's that molecular pathology is there on the line?
Yeah, Mrs. Celebration, Dr. Celebration can answer that question.
Thank you, Vijay ma'am, for this excellent question. Actually, this is one of the very important questions also for this. So when it comes to molecular NGS, so those tissues which have the necrotic or the blood clot should be avoided. We cannot do any molecular testing in those samples basically. So we need to remove those blocks which have the necrotic tissue, number one. If it is having the blood clot, also need to be removed. It would be better for the molecular testing, at least one tissue block. One tissue block. If we have two blocks, at least one tissue block, we need to keep separately, exclusively for molecular testing. Be it a 12 gene or be it a 50 gene or 150 genes or 300 genes, one block exclusively for NGS testing, we can keep it up. If the doctor is deciding that they want to go for further targeted therapy or immunotherapy for this patient, it would be better. Especially recurrent tumor, one block would be best to keep it for the NGS separately. And the tumor content minimum, it has to be 20 to 30%. But always I would suggest, if it is 60 to 70%, 80% tumor content in the block, please preserve that block for the NGS. Because the more the tumor content you are going to be, the more the patient is going to get the benefit out of it. So whatever the things it is going to be, we will be able to identify it in that one actually. So
no,
I hope.
No, but my question is, if we get a block with multiple pores in it, already, so then what do we do? How do you people, deal with such blocks?
Number one, as madam said, we should request all the pathologists over here, please avoid multiple cores in one block. Whenever there is a tissue, at least we need to have two blocks, at least 3 blocks we need to prepare, so that one can go for ISC, one can go for. But in case, if they have done all the core blocks into one thing, only one option left over for us is the macro dissection. So the macro dissection also need to be very carefully done. It's a very tedious job, and it's a very, very risky job also, I would say, actually, to be frank with you. So that's the only option. But once the core block, every block, tissue is put it in one core tissue, that's it, end of the story.
So solution is at least 1 or 2 cores only in one block max. Neena,
Yes,
that's what you
exactly,
right?
That is the.
So I think we'll start doing that.
Yeah, that
but
is.
Then the problem comes when we get blocks from outside for second opinions. There lies the problem then. So we can't do anything about it.
Exactly.
But then, I think we were lucky enough, we have not got anything as negative, I guess. So I think I need to do audit like we have done to find out where we stand. That's a
Yeah.
good suggestion you gave us.
Mhm.
Okay, thank you, Neena.
Thank you, madam.
Thank you, ma'am.
Neena, I have no questions. I just want to congratulate you as the talk, taking the pains to repeat the talk for us who cannot
Yeah,
join last time.
Thank you, madam.
Thank you very much, Neena. This is a curtain raiser talk for your topic on precision oncology. And you took us through the different aspects and important things that upcoming area for the younger generations to specialize and, to take the lead in patient management. The role of pathologists in patient management is stressed very well, Neena. Congratulations. Well done.
Thank you, madam. Thank you so much for being here.
This is Dr. Ashik. Can you hear me?
Yes, yes, Ashik. Yes.
Yeah, Ashik. I have a doubt here. It's both to Neena and Nilambrasan. And on a big tissue, how do you score it? On the small tissue, how do you do the percentage, like percentage tissue score?
Ashik,
Uh,
actually, what we do, like if you have, for example, core needle biopsies.
yeah, in that it's one or two cores. One core it will be very less, another core is bigger.
Yeah, that's all. I
Uh,
mean, what is required is that maximum tumor should go for
then
molecular.
how much percentage would you give it?
Meaning you have two blocks and you have more percentage in one, less of the.
That is if it is a big tissue, right? If it is a big tissue,
you can
also
give a
say
chunk of tumor. You can give a chunk of tumor for the molecular.
I mean, big tissue with few volume. At the corner, if you have a good volume of malignant cells, I mean, that also low percentage we usually give it, no, in those cases.
No, if you have a major resection, obviously,
Yeah,
chunk of the tumor you can give a big block to the molecular.
molecular. Okay.
If it's only the problem is when, as Vijayalakshmi madam said, when you have these core needle biopsies, if you have two blocks and you have two cores and one core is showing more tumor, give that
Give that core to the
that
molecular. Yeah, we usually do that. It's a bit for them. Okay. Thank you.
Ashik sir, just to repeat the request you mentioned for about the percentage of tissue that tumor content.
Yeah.
So the percentage they are requesting in the lab is minimum is 20%. The more the number of, yes, 20%. Okay. The more the number of genes we are going to do, obviously we need more the tumor cells in that one, so that we can extract the amount of DNA will be from the tumor. The problem will be if we are giving 10% to 20%. Okay, let's put the calculation like that. So what they will do, they will do the cross cutting and they will take the entire tissue and they will do the DNA extraction. So what will happen? 90 to 80% of the cells are normal cells you are having. So the DNA is
90% it will be normal cells.
Exactly.
Correct.
So the tumor, the DNA extracted from the cells are from the normal cells. So the chances of
is it we required to mark it and take it out the specimen, or is not required, right?
Not required. Not required.
So Lamashan, I have a question to you at this point.
Yes, ma'am.
See, sometimes we get the when we send for NGS, will we get the block back?
Yes, ma'am. Always 100% in foundation medicine. If it is missed out, you can also request at any point of time. They will have the responsibility to give back.
Which means you are not using the whole block for your NGS.
Yes,
you're
ma'am.
only taking. So how do you take tissue from the block for NGS?
So as usual, they are doing the H&E staining. So they will cut out about 4 micrometer to max 10 micrometer to extract the DNA for the first round. So the minimum DNA extraction is 50 micrograms to 100 microgram. It's again depends upon the lab to lab, the technology to technology they are using it out. So after using it out, there will be lot of blocks will be available to use for ISC. So always you can request.
So any molecular test, you will return the block, isn't it?
Yes, it has to be written. That is the responsibility of the lab should do that. I'm not sure about in Indian labs how many of them are repeated, but it's a good suggestion. Every pathologist should request for the same thing.
One question from my side, Silumarasan.
Yes, ma'am.
You know, when we send the blog, do you first take a H&E slide section for H&E staining and then look at the slide and then decide? Because especially when you have multiple cores, as I mentioned you earlier, you have to decide whether the core is, whether the what
So
sections you're taking does have tumor tissue. Even though we give you the slide, the blog, you should be sure, no, which core you have to, which one, which fragment has the tumor cells, etc. No.
So I will tell you my practice when I was in Singapore. So what I do is that always I will request for the block as well as the respective H&E staining, whatever they have done for that particular
That
block.
is good. That is good.
That is
That
good.
is good.
That is what.
That is
But
right.
yeah, that is the
That is
right
good.
thing to do, I guess.
Provided
good.
the block contains adequate tissue.
Ah.
Yeah, that we have to make sure.
For them. We give them a good HND slide, enough of tumor, and the block will be exhausted, then it's no use.
No. We'd ask a technician whether it has enough tissue before we give it. That's what we do.
Yeah, that's it.
So for
That
two
is good.
reasons, I used to get the block along with the slide, ma'am. So the
Okay.
number one, I will be able to understand whether the tumor content is adequate or not. Number one. Number two, sometimes like Dr. Asik sir mentioned, some of the times the tumor will be lies in the corner, somewhere in the edges here and there. So that will help me to do the macro dissection in that particular area and then recount how many tumor content are present over there, whether it will be adequate for the DNA extraction or not. Then it will be easy for me to proceed for the NGS testing after that, actually. So that's
What is it?
Yeah.
Okay,
That,
continue. Okay, sorry. Now, what is this macro dissection? What do you do actually? Take a core, right?
that you can do it.
So same tissue. Only thing is that normal area, the vacant area, all those places will be left out, and then the section will be focused on that particular area where the tumor have, and then redo the calculation. Just it's for the calculation purpose, basically.
Okay.
It's like instead of 4x, we are doing it in the 10x, and then zoom that particular area and focus, and we will see, right? So like that area will be focused and do the dissection. That's it.
Okay. Right.
I think Prasida madam has raised her hand. Madam, please unmute yourself. Prasida madam.
I think some technical issue maybe. Ma'am, I think could need unmute, so she left.
Okay.
I think we'll have lots of questions to ask our molecular pathologist in the next talk.
Next section will be very interesting. Going to
All these questions will be more clarified perhaps in the
Yeah,
next
we're waiting, looking forward to his talk.
Madam, just one question. In which all cases you consult with the oncologist that whether the IHC should be done or molecular if the tissue is too less?
Yes. So we have our practical challenges there also. For example, a block that is coming in from outside may not be looked into by our own, may not be going to be treated by our own oncologist. It may be going to be treated by another oncologist. So you won't know which oncologist to consult, isn't it? In which case you will have to make your own decision, your own judgment on the amount of yourself and your technician together on how much tissue will be remaining after you do your IHCs, or will it be sufficient? For example, for a particular case, for example, non-small cell lung cancer, will there be enough tissue for both? If you think there is not going to be enough tissue for both, then do not attempt an IHC at all, because the treating physician wants the molecular more than your diagnosis or your IHC. So it's our judgment.
Prasida madam is I think now joined back. Prasida madam?
Madam, please unmute. Some issue.
Madam, that microphone area you can just click on. extreme left.
Madam, you're still mute. Prosida, madam.
Yes. Now okay. ma'am.
Yes, yes. Now you're unmuted.
Very illuminating talk, Dr. Leena. Just wanted to say that.
Thank you, madam. Thank you. Thank you.
And thank you for doing it again.
Thank you. That was a glitch on our part. That's why.
Welcome.
Thank you so much.
So if there are no more questions, can we conclude the session?
Yes.
So thank you all for the active participation. See you all next Friday, same time, 7:30.
Thank
Good
you all.
night.